Professor Hann, a number of further questions suggested by core participants that I'm going to ask you about. In terms of the facilities at York Hill on your arrival, what were the available laboratory facilities, and where was the testing on factor levels and ALT levels undertaken?
Basically, there was a main, right next to my office, there was a main laboratory, and then next to it there was a blood transfusion area. That was it. The clotting initially, coagulation testing was done in the main laboratory, and then I was able to send, with support, I think mainly from charity again, a lady to Canada because Dr. Gibson had worked in McMaster and was able to get additional training for that person, and she came back and ran the clotting lab thereafter.
So in terms of testing for ALT levels, was that undertaken where you've described in York Hill, or was that sent off elsewhere?
No, that was just down the corridor in biochemistry. Dr. Logan, I think it was.
Who would you say was responsible for the lack of facilities and staff which you observed when you arrived? Was it the Health Board, Dr. Willoughby, the Scottish Home and Health Department, or a combination?
Difficult to say. All I know is that when I came there, there were a lot of people who were trying to help me improve things, including people in the Health Board and all of the areas that you mentioned. I think Dr. Willoughby was possibly even worse at politics than me. I can only pass on things that other people, hearsay from other people, really, to be honest with you, in that they said that he didn't fight hard for things and such like. I really honestly don't know, but it's important to understand two things. First of all, this was pediatric hematology, and looking after children with leukemia and blood disorders, bleeding disorders, was a relatively new thing. There are a lot of very poorly resourced departments, including Great Ormond Street at the time. There was half a haemophilia nurse when I went there, and a store cupboard converted into a bleeding room and an area you could barely get in through the door where you treated patients. When we started doing external audits, my first visit was to Belfast, to the unit there. Some years later, around about 1990 probably, to Dr. Elizabeth Main, and there was essentially no haemophilia centre there. It was a matter of using beds on the ward or maybe areas in clinic, etc. It was a common problem, as I say. Although things were designated as centres, they weren't resourced as centres. There were exceptions to that, and the best exception by a long, actually, Royal Manchester Children's and Alderhay did not have any designated centre area either when I'd been there very recently. The best example of a well-resourced centre, and one of the very few at the time, was the Royal Free, the Catherine Dormandy Centre, which I think had started in a caravan. But with the rebuilding of the hospital in Hampstead, as some of you may know, it was all singing and dancing. And sorry, as far as staff are concerned, yes, it was, I think that there was, I've already said there was a lack of subspecialisation in paediatrics in Scotland at the time. It was not given a high priority really by anyone until Dr. Willoughby left and I came, and his leaving was part of the drive towards this. There were a whole series of appointments in paediatrics and areas of general paediatrics and neonatology and so on, yet I couldn't get a paediatric oncologist on board. I did manage to get Dr. Gibson there, which was a godsend, and she was extremely good. But getting other things like facilities, I had to raise the money myself.
You described communication issues as the biggest problem on your arrival. How did those problems manifest themselves?
Well, let me put it this way: all the things I was used to, very little existed. I was used to social workers with family therapy training. I was used to clinical nurse specialists who often had counselling training. I was used to the availability of psychologists to a somewhat limited degree. And I had, as a trainee, significantly more time available and personnel available to carry out communications. But in addition to that, I noticed that a number of families were not part of the Haemophilia Society and didn't seem to know it existed, and I had to push that very hard. I was very used at the Royal Free to routine clinics. In fact, there were clinics every day there virtually. And so that was something that needed to be sorted out immediately. And then at Great Ormond Street in particular, through the palliative care and home care teams, I was used to the communication, the excellent communication skills of proper paediatric trained nurses and nurse counsellors through parents groups, which were either ad hoc on the ward or whatever, but very often, for instance, bereavement counselling sessions and information sessions, like for instance, when there was a new leukemia trial, etc., there would be open sessions, town hall type sessions. And also on top of all that, there's an absolute need, which had not been recognised at the time, for independent patient advocacy, if you like. Something that came later on at Great Ormond Street, that was actually just inside the main door of the hospital, probably still there, was the patient advocacy team, which I fought for with many other people, and which reported directly to the chief executive, and to which people could drop in and was entirely confidential. And also the extremely important role of social workers. I would just add one thing, and this is not intended to be pejorative, but the attitude towards social work at the time needed a bit of a revolution in York Hill. And the attitude basically was these people were there to sort out a bit of extra money to buy fridges and freezers, a bit of extra clothing, etc. And how dare they step on our toes when as nurses and doctors and so on, we are there and we understand how to talk to people and how to communicate and all that, not realizing that there is an absolute need, especially in this sort of area, and especially when there's a lot of grievance and grief and so on, for somebody independent with proper skills to be available to them. So I'm sorry I'm being very verbose, but it was something that I had to fight for very hard. And fighting for resources is one thing, and I wasn't all that good at that. Fighting for a new ethos is even more difficult. But with the appointment of a very good social worker for the leukemia, solid tumours, etc., and the involvement of Miss Leach, it improved dramatically. And I think her input as what I would call a patient advocate is, especially times of crisis, is so important.
How did parents react to the changes you implemented in terms of the switch to SNBTS concentrate and the cessation of prophylaxis?
There was, I have to be honest with you, and this was dealt with almost entirely by Anna Pettigrew and Nurse Murphy, and they fed back to me, and I did talk to them in the clinic about it and so on. There was a little bit of a reaction because, the marketing of the product was obviously, as you would expect, better with the company, the nice packs and bits and pieces and swabs and butterflies and all the rest of it. And I have to say their product information, or pills as we call them nowadays, leaflets within the packs, which actually dealt from the mid to late 1970s quite well with the risk of hepatitis being there. all of those things were preferable. It was of higher purity, and they knew that. But basically, I just said to them that I can't prove it to you, but you know, it's almost common sense that the approach of, in most respects anyway, of the SNBTS was, and the blood transfusion service throughout the UK was preferable.
One of the aspects of your policy changes was to try and keep concentrate use to a minimum. How did you control concentrate use amongst those who were on home treatment?
I didn't actually really control it that much. The only thing that I did, well, two things really, was that I reduced. It was very important to me and to the country at the time that we preserve the supply as much as possible, so that we didn't have to go back to the use of commercial concentrate. So I had two reasons to stop prophylaxis. First of all, it wasn't working in the way it was being given for those patients who were on it. And secondly, with patients who were on home therapy and so on, it was a routine anyway to be sure that it was being used in not a profligate fashion. That very, very rarely happened anyway. So we didn't say to people, you can't do this anymore. What we said to them was, prophylaxis isn't working. We do need to maintain the supply. I would advise you that we should cease prophylaxis until we know more about how it should work or whatever. And I don't recall any major pushback to that, although one or two people were a bit fed up with having to spend longer. It's just a few minutes longer drawing up the product, which was of lower purity from the SNBTS.
Were you aware, from your work in the field of leukemia, of the work in the very early 1980s of the Gallo group on HTLV 1 and 2?
I had actually met Bob Gallo at various meetings and so on. I knew his main interest was, to my knowledge, in bone marrow transplant and so on, but I may have been aware of it. It wasn't something that HTLV, which did you say?
1 and 2.
No, HTLV is still a problem to this day as a T lymphocytic virus. I didn't actually know that he was particularly interested in it, but I was certainly aware of HTLV as an issue in leukemia patients and so on. It's really a problem arising, my memory is, out of the West Indian population and so on.
In the period when you were at York Hill before you learnt of the HIV infections in your patients, were your patients tested for immune function deficiency? Were CD4, CD8 counts undertaken prior to their diagnosis?
I don't think so. I was very much aware of one issue which I've regarded as a somewhat ethical issue, which is that I don't think it was suggested in Scotland, but it was certainly suggested at some of the meetings I was, that one could surrogately test for HIV by doing CD4 counts. I did not approve of that approach. If there was anyone who had, and there were not to my knowledge, if there were anyone who had shown any signs of AIDS-related illnesses of any description, we would certainly have done it then. I don't think we did, no. I certainly didn't have any research protocols of that nature. It would have been along the lines of, we need to do this because the patient might be considered for pneumocystis prophylaxis, for instance.
Was any research undertaken on your bleeding disorder patients during your time at York Hill?
Yes, I've already mentioned Dr. Markova in Stirling, who'd had a long, prior to my being there, I think, had an interest, and I encouraged that interest because we needed more psychological, psychotherapeutic sometimes input. Her interest was mainly in coping procedures and in children with haemophilia, things like, what could they do with regard to sports? Were they scared to death of knives and so on and so forth? How did they manage scratches, and how were they adapting to their life with haemophilia? And that was done as far as I'm aware, with the full consent of those taking part. She was a psychologist, I'm so sure, and she was a very good psychologist. She published quite a bit, which some haemophilia families read, of course. And I'm sure she explained it in a consenting way.
Was there any other research in which the patients were involved, to your knowledge?
I can't think of anything else, no.
Just going back to the issue of the letter from Dr. Follett and the process of testing for HTLV3, do you have any recollection as to whether that letter contained only the results of patients who were still York Hill patients, did it also include patients who by that time had moved to the Royal Infirmary in Glasgow?
This really was why I pointed to Dr. Lowe may be able to help more. As far as I recall, and I think I read some of Dr. Pettigrew's statement that it was the same, that there were about 8 or 10 names on that list. I'm as sure as I can be, but I'm not absolutely certain that there were no transferred patients' names on that list. The fact that they were done at the same time may give you a clue with Dr. Lowe as to when those tests were actually performed.
Did Dr. Gibson have any involvement, as far as you can recall, with the process of testing?
I very much doubt it. I don't think so.
You referred, I think in one of your answers earlier, to the possibility of a patient having been infected with HIV from cryoprecipitate. Are you talking there about a York Hill patient or elsewhere?
I'm sorry, I don't have the list in front of me. Within my statement, I've just reiterated what Dr. Chalmers did. It's there in black and white. I never did what I know Sir Brian was describing, what we still call a look back. I never did that, but my memory is that there was a patient who developed HIV from cryoprecipitate.
But you've taken that simply from the work recorded in the Penrose report, is that right?
Correct. From that table, the one you...
Yes.
Yes. Well, and it's actually, and there's a sort of diatribe that goes with it as well, yes, which describes where it was possible to try to elucidate whether it was SNBTS or commercial or cryoprecipitate. That's stated and I put it in my statement.
What, if any, psychological or other support was provided specifically to the parents of the children infected at York Hill?
Well, we've already stated the difficulty that there was with mothers being involved initially, but we always encouraged them, if possible, to involve the other parent or partner. And when it came to the parent support groups, everyone was invited. There was never any question of identifying people who were positive or not positive. It was generic initially, and then I believe that the social worker and the parents themselves held parent groups themselves. We certainly, and Dr. Pettigrew, I spoke to one group, and I know Dr. Pettigrew at least spoke to one group, if not more. It's possible that the invitations didn't get out to everyone, and that's regrettable. But I think that we made every effort, and the social worker and others certainly made every effort to get everyone there that could be available.
Dr. Pettigrew's evidence in relation to patient records was that records were retained at York Hill when a patient was transferred to the Royal Infirmary in Glasgow. Is that your recollection? And if so, what was the purpose of that?
Not sure there was a specific purpose. It was basically, it was the case, yes. We occasionally loaned out case notes, but sometimes for all sorts of reasons, you get contacted at a later stage about somebody asking for information about a patient obviously in a confidential manner. So my attitude was, I sort of ignored the 25-year rules and so on, and I always said, both in York Hill and at Great Ormond Street, that we should retain the records of these patients forever. That wasn't always followed, of course, but and that causes problems when there are things many years down the line, as there sometimes are. So, and we still worry about that side of thing in blood transfusion. How long do you keep half-life questionnaires? 10, 20, 30? Simple laws don't really help you in those circumstances always.
In the period from the end of 1984 through to April 1987, so the period when the SNBTS product protected in relation to HIV but not in relation to non-A, non-B hepatitis, were you aware of there being in Scotland any supply of 8Y, which was the BPL, the Elstree produced product?
Yeah, I know 8Y quite well because I also used it and did so afterwards. I don't recall ever using 8Y in Scotland. It was a very good product in many respects, had a very low inhibitor risk, apparently, but I don't recall using it in Scotland.
Final question, Professor Hann. You referred in your evidence, I think this morning, to UKHCGO as a doctors-only organisation. Who else do you think could or should have been involved to broaden it out?
Yes, well, I was a bit of a lone voice with this. I probably might well still be. I believe very strongly that most of haemophilia care should be nurse-led. It's always from the mid-1970s been a home care type of approach, a daycare type of approach. Coordination of such patients, doctors are very bad at that on the whole. The nurses have nurse counselling expertise, or should have, and I really thought that at the very least it should be broadened out to include them. I don't think there's any specific reason why you only have a doctors only. Well, originally it was only reference doctors. It then became broadened out to more doctors, but certainly the annual general meeting could have been for nurses. And I would just reiterate that there was one thing which was remarkable, which was the World Federation of Haematology. It was one of the very first meetings ever where everyone, including the patients, was invited. And they took a very active part in it. And by the way, were supported by the commercial pharma companies to do so. So yes, you could say everybody, and maybe there should even be a national UKHCO which includes patients. But as far as the planning goes, it would certainly at the least be important to include nursing, and you could also consider including physiotherapists and social workers up to a point. I mean, sometimes when you're dealing with very technical issues, you have, as the World Federation does, you have breakout type of approaches which are intended to be more of interest as opposed to keeping people out. So yes, sorry, long answer again.
Professor Hann, those are my questions, and I understand that your counsel, Mr. Barry, doesn't have any questions for you. Sir, over to you.
Yes. When you were answering questions this morning, you talking about heat treatment, and you said I think, talking about haemophilia doctors generally, we were crying out for pathogen reduction techniques, talking about it for years. We wanted it, we needed it. Can you tell me a little bit more about the years during which you were calling out for pathogen reduction techniques and what you had in mind particularly?
You may be very surprised to know that that's exactly what we're discussing at this very moment. Well, not today, tomorrow probably. Pathogen reduction techniques for transfusion-transmitted infections are still a major problem. They are going to continue to be a major problem, and they're very unlikely to go away. And Zika virus, it usually takes a crisis for something to improve, and that's what happened with HIV. It happened again with Zika virus, such that the Americas, USA particularly, introduced pathogen reduction techniques for cellular products, which are much more difficult to deal with than plasma products. So Ireland, for instance, and the UK are looking again, and we hope to introduce very soon pathogen reduction techniques for platelets and then for red cells, because transmitted infections still occur. As I've said, we had hepatitis a few years ago, and we are still at risk of malaria, which can be fatal, and other organisms, bacterial organisms such as Serratia, Staph aureus, etc., which can also be fatal. So the answer to your question is that in the years prior to 1983-4, we knew that hepatitis B was a problem and that it wasn't going away. It still hasn't gone away, and we needed something that was safer with that. We did not foresee, I don't think anybody did really, to be honest, HIV coming down the line. It was out of a clear blue sky as far as I'm concerned anyway. But as soon as that arrived, it just kick-started things at long last. Prior to that, we had been discussing Hep B and then non-A, non-B hepatitis. From 1980 onwards, certainly at the Royal Free, I remember speaking to Dr. Kernoff and him saying we need some sort of, is it going to be solvent detergent, heat treatment, what is it going to be, ultraviolet light, there were lots of discussions at the time, but there seemed to be no imperative until the crisis. We had wanted it for years before. We had wanted self-sufficiency, and we had wanted pathogen reduction techniques, and we had wanted pathogen reduction techniques that did not compromise the supply and did not cause inhibitors. And that was part of the problem, because all pathogen reduction techniques do affect a little, thankfully, although initially we thought it was much more, do affect the supply, and the supply was crucial. And I certainly didn't want to go back to using commercial concentrates again. Sorry, I hope that answers it to an extent.
To an extent, yes. You described, I think, a clamor certainly from 1980 onwards, but the implication of years and going back to the arguments about self-sufficiency might suggest it was earlier still.
Oh yeah, it was. Because we did know about, as you know, you've been through it in great detail, that non-A, non-B hepatitis was known about. The peak incidence was around about 1968, in fact. Because you didn't see it much in children, because for some reason they very rarely have acute episodes, but it's been known about in adults for a long time. And we didn't know whether it was going to be a very minor thing, although that was often the consensus, or whether after 1980 it was going to be a prevalent serious thing or a rare serious thing. But whatever, we needed, and there were a lot of people, including in the haemophilia fraternity, who said, we need to be careful about the next thing that comes down the line. I don't know that they were expecting anything like HIV, but they were certainly thinking about it. There's no doubt about that. And so there was a clamour, yes.
So
but we couldn't get to self-sufficiency, let alone reducing further the amount that we had. Sorry.
So is it the case that more or less for as long as you had been practicing in medicine, in training first and then later on practicing, there have been some discussion about pathogen reduction techniques?
Oh yes, absolutely. Including, well, because, at least in part because of the hepatitis B problem.
But your sense was, until 1980 anyway, little imperative to get on with it.
I think people like Dr. Kurnoff and so on were very keen for it to happen. I mean, I remember him saying to me, the first dose of this concentrate is going to give people non-A, non-B hepatitis. It was really a question of whether this was going to be like hepatitis E or G or D or A, where it was something that was just eradicated in everyone or nearly everyone, or was it going to be, thankfully, not 100%, but 60% or whatever it was, who developed chronic problems. It was always regarded in the people that I spoke to, it was always regarded as important.
Thank you. You told us that your view in May 1983, this is I think by reference to what Montagnier had been saying in the Pasteur Institute, that it was more and more likely, that was the expression you used, that HIV, you said, I think LAV is what he called it, had been transmitted. And you corrected the tense. But the more and more likely, does that mean you thought it probable, or it was just a possibility which is becoming a greater possibility, or what?
It was a probability, but again, I'm sorry to keep harking back to prevalence and so on. We didn't know what proportion. It ended up something like 16. It was less in Scotland than in England. It was 16%. Was it 20% or something like that? But the fact is that yes, it was very likely by that stage, in my estimation, that it was a transfusion transmitted infection. We did not know in haemophilia as yet how serious this was going to be and what proportion would develop AIDS and how long that would take or whatever, or whether it was going to be eradicable in some people. That, like hepatitis C is, that turned out to be a false hope, unfortunately.
The next question is in relation to something you were quite self-critical about. That is where you told us that you should have done it, that is pre-test counselling, better. In what way would you have done pre-test counselling better, albeit looking at it in retrospect?
Really, I can deal with it well in retrospect, I think, because it was in the forefront of my mind when hepatitis C came along in 89, 90. How do we do this, and how do I not repeat history and not learn from it? And basically, what we should have, it was difficult because we didn't have a test that was reliable up until we got the results. So what I should have done better was to contact virology to say, have you got samples? Will you test them? Will you let me know? I understand you're testing out various things with tether and people to see if it's specific and sensitive and so on. And then go back to the families and say, right, we are going to test this sample as soon as we know, and Dr. Tedder is going to let me know when that is likely to be. And then that opens up a whole series of questions which were not adequately dealt with at the time, which are, what if it's positive? What if if it's negative, is that fine? Is it negative forever? Is it like, can you be infected even now? All those sort of questions would have been much better dealt with pre-test counselling, and I greatly regret that I didn't spend more time, or at least realise that was a gap at the time.
What do you think the effects of not doing it in that optimal way may have been?
Well, I think it would probably have come as less of a shock to the families because they would have been better informed about the potential outcomes. I've said throughout, and it really is a difficult situation, telling people about potential terrible news when actually it might well not be irrelevant, might not well be relevant. It's not an easy thing to deal with uncertainty which goes from one pole to another, life-changing to just carry on. It would, I believe, have. There were no complaints at the time, and I'm amazed. I suppose they were just so dependent upon us that they would not complain, and that's a matter of even greater regret. But the fact is that they would have been better informed. They would have been stimulated, if you like, to ask more questions and to be better informed. Although there were lots of other means of information, I think it would have been a much better situation. And it's not something that I feel in any way comfortable about ethically, retrospectively, despite the fact that I can't remember ever asking for this to be done. It was needed.
Finally, you have a perspective which few of the witnesses to this inquiry have, in two respects. One is, having been so involved during your working life in the blood transfusion service as well as in pediatric hematology and the care of children with haemophilia, but also having done it in Ireland as well as in this country.
Yes.
By Ireland, I mean Southern, or the Republic of Ireland.
Yes. Since 1940s.
Yes. But,
still a member of the European Union.
Yes, well, my grandfather was an Irishman, so I know parts of it quite well. But what are there any lessons that we can learn here from from your experiences, what your experiences tell you about the way in which the Irish Republic has dealt with matters or is dealing with matters?
Well, you may not like the answer to this. I think that the fact that the Lindsay Tribunal was held at a time when people's memories were better and where data collection and it was fresh in many people's minds. I mean, it's still to a certain extent fresh, but it's a lot of what I say to you, and I have to be perfectly honest, is relearned memory, and I really hate that. Because what I want to tell you is, and I mean this, is my actual memory of the time rather than reading through hundreds and hundreds of pages that I get sent. The fact is that the Lindsay Tribunal was extremely well carried out. You don't want to learn anything from it from the legal profession point of view, because of course now it's become virtually impossible through massive cost and through the Supreme Court judgments here that you can't really name and shame people anywhere near as necessary as it may be necessary in inquiries here. But what a lot of good came out of the Lindsay Tribunal, the most important of which were the resources and the governance and the quality control. I mean, you might say, I'm still working at blood transfusion, that blood transfusion has become extremely risk averse to a level that at times makes me worry about efficacy and so on and so forth. In fact, the blood supply in Ireland now, because of things that are good that have come out of the previous inquiries, and I hope this inquiry too, is that the blood supply now is often on a tightrope. And we've just been through an extremely taxing period for myself and others where the supply has been extremely compromised. The health life questionnaires now mean that which are applied very, very rigorously and looked at externally and legally. It's 100% traceability is a legal requirement in Ireland now. I'm not sure that it is in England. You have to be able to, sorry, I'm rambling slightly, but in the Ognall inquiry that I dealt with, one of the biggest problems was things like records from Great Ormond Street. Where are they? Who had what? How can you do a look back when you don't know what people receive, etc.? So of that came the Product Liability, or what I call Product Liability Consumer Protection Act, etc. Within Ireland now, the similar thing happened because of Lindsay and so on, and we now have an absolute requirement for everyone who uses blood products to have a complete traceability, which has to be verified and annotated. And the final thing really is that they went from having one haemophilia doctor to having a whole cohort now and a proper built centre and excellent governance. It's revolutionised haemophilia care here. I think there's no doubt that you will find, I'm sure, it difficult to make judgments of things that happened a very long time ago. They were in a better position in that respect, and it's possible that the record keeping and so on was better here than there. But from the Irish point of view, haemophilia care now is extremely well run. The governance over it is very, very tight indeed, and the management of such patients is as far as I'm concerned, optimal. And a lot of that came because of that inquiry. A lot of good came of it.
Well, those are all the questions that I have to ask.
Professor Hann, is there anything further that you wanted to add?
Well, I want to say two things really. First of all, and it'll be very brief, I want to thank you and Sir Brian for letting me ramble on in a very verbose way sometimes, because I had 2 pages of things I was going to say here, and I've already, I think, said them all. Which leads, and I do think it's very important that the inquiry takes on board the special requirements for children and paediatric care and paediatric haemophilia care and all those aspects that I've talked about. And I do hope that good comes of this for reasons I've already stated. It's an ongoing problem and an existential problem. The final thing I want to say is, you've already heard a lot of people say that the worst thing you can do if you're in your right mind as a doctor is to do harm to people. Unfortunately, harm does occur. A tragedy such as this is not absolutely unique, but it was unique in my experience, and it was a terrible thing and caused terrible suffering to the families. And I just want to apologize again for the additional harm that I caused through not communicating well enough. Thank you.
Thank you, Professor.
Well, Professor, you've given us a very different perspective in many ways from the perspectives we've been listening to, because yours is the perspective of somebody who is a paediatric haemophilia doctor, in part, if I can call you that. You've not held back at all in what you've had to say and your views. And it's seemed to me that you've given us a very graphic picture of what it was like to start in 1983 with a huge range of responsibilities and very little resource, and a system which needed to be changed as you saw it. You've, I think, shown that your approach was to do it not as being the king who is a doctor or a consultant, but as part of a skilled team working together, which you described right at the end of your evidence as the ethos which you wanted to instill. And it struck me that you've been restless throughout your career, as you've told us, and indeed in your evidence, restless for improvement. So I'd like to thank you in particular for all that. And I'd ask you, for your part, to forgive me and us for having taken up your day and prevented you from getting out to enjoy what may be a rare Irish experience, that of sunshine, as you told us this morning.
Thank you. I'm very grateful for the opportunity.
So we resume tomorrow at 2 o'clock with the commencement of the evidence of Professor Lowe.
So 2 o'clock.
2 o'clock tomorrow.
Tomorrow morning. Tomorrow afternoon. Yes.
Yes.
2 o'clock.